Hello everybody and welcome to our module on extrinsic hemolysis. In the module on basics of hemolysis, I talked about how you could divide normocytic anemias up into two groups. Normocytic anemias are anemias where the MCV is usually between 80 to 100 within the normal range. And you can divide the normocytic anemias up into those that are caused by underproduction by the bone marrow and those that are caused by hemolysis or increased destruction. And of those caused by hemolysis, there are those that are due to some cause intrinsic to the red cell, and there are those that are due to some cause outside or extrinsic to the red cell. And in this module, we're going to focus on the hemolytic anemias with an extrinsic cause. So in general, there are three causes of hemolytic anemia that are extrinsic or outside the red blood cell. The first one is antibodies, the second is trauma or shearing of red cells, and then finally there are a small group of red cell infections that can cause hemolysis. So we'll go through all three of these now. So autoimmune hemolytic anemia is a fairly straightforward condition to understand. It's a condition where there is red cell destruction from autoantibodies. It results in extravascular hemolysis. When the red cells get coated by antibodies, the red cell membrane is removed, usually in pieces, by the spleen. Therefore, it's extravascular hemolysis. You might think that antibodies could activate complement, but remember that red cells have many proteins on their surface to protect them from complement activation. So generally, complement doesn't get activated by antibodies and destroy red cells inside the vasculature. Instead, they are removed by the spleen. And there are two subtypes of autoimmune hemolytic anemia depending on the temperature at which the antibodies bind. One is called warm and the other is called cold. Let's talk about warm hemolytic anemia first. This is the most common type of autoimmune hemolytic anemia. In this condition, antibodies bind to red blood cells at body temperature of 37 degrees Celsius, hence the name warm. In this condition, IgG antibodies develop against red blood cell surface antigens, and this is what leads to the hemolytic anemia. The signs and symptoms of this condition are the classic signs and symptoms of anemia. So this includes fatigue. Patients can develop pale skin or pallor. They can develop dyspnea. When you are anemic, you cannot deliver enough oxygen to your tissues, so you develop dyspnea. In addition, you can develop a tachycardia, particularly at rest. That's because not enough oxygen is getting to the tissues, so the body is responding by increasing the heart rate. In addition, in warm hemolytic anemia, patients develop extravascular hemolysis. That's because the antibody-coated red blood cells are removed by macrophages in the spleen. So this leads to jaundice from the increased bilirubin levels. In addition, patients can develop splenomegaly as those macrophages in the spleen hypertrophy, trying to consume the red blood cells coated with antibodies. The classic finding on peripheral blood smear in warm hemolytic anemia is the presence of spherocytes. This is an example of a spherocyte on the screen here. Note that it's slightly smaller than normal red cells. It's spherical in shape. Note also that it lacks the central pallor you usually see in red cells. The reason spherocytes form is because the red blood cells in warm hemolytic anemia become coated with IgG antibodies. The splenic macrophages are unable to engulf the red blood cell whole. I think of it as the IgG antibody getting in the way of the mouth of the macrophage, so it just takes a bite out of the red cell instead of engulfing it whole. As a result, the red blood cell shrinks in size and becomes more dense, and that results in the formation of spherocytes. Now, there is an inherited disorder called inherited spherocytosis, where spherocytes also develop because of abnormalities of the cytoskeleton proteins inside of the red cells. Spherocytes also develop in warm hemolytic anemia, but the mechanism of their formation is entirely different. So let's imagine that you have a patient who presents with classic signs and symptoms of anemia. You do a blood test and determine that it is a normocytic anemia. One of the first tests that you then want to do is a reticulocyte count. And the reason you want to do this is because you want to determine whether or not the bone marrow is producing enough red cells. Now, if the reticulocyte count is increased and indicates that the bone marrow is producing enough red cells, then you know that you're dealing with a hemolytic anemia. And one of the first tests you want to do in that situation is called the direct antiglobulin test, or the Coombs test, because this is a test for red blood cell antibodies, and it'll determine whether the hemolysis is due to autoimmune hemolytic anemia. For this test, you take the patient's red cells and you add anti-IgG antiserum. The test will be positive if the anti-IgG antiserum causes the red cells to agglutinate. That indicates that the patient's red blood cells are covered with IgG antibodies. To make this more clear, let's look at the picture I've drawn on this slide. The direct antiglobulin test starts with the patient's red blood cells. You then add anti-IgG antibodies. Now, if the antibodies in the red cells all swim around together happily with no agglutination, that means the test is negative and there is no IgG covering the red blood cells. You then need to go look for other causes of hemolysis. On the other hand, if the red cells agglutinate, this is a positive test. It means that the patient's red cells had IgG on their surface, and the anti-IgG antibodies were able to bind to that and cause the red cells to agglutinate. That is a positive DAT or Coombs test. Now you may be aware there is another test called the indirect antiglobulin test or indirect Coombs test. This is also a test for red blood cell antibodies. However, this test is not generally used in warm or cold autoimmune hemolytic anemia. However, let me explain how this test works so you don't get it confused with the direct Coombs test. So this tests for antibodies in the patient's serum. In this test, you are testing the patient's serum, not the patient's red blood cells. You take a sample of the patient's serum and you add it to sample red blood cells, and the test is positive if there are antibodies in the patient's serum to the sample red blood cells you use as part of the indirect antiglobulin test. So here's a depiction of how this test works. You begin with the patient's serum, not the patient's red blood cells like we began with in the direct antiglobulin test. You then mix the patient's serum with red blood cells, and these can be any red blood cells we wish. For example, this test is commonly used to see if a mother who is pregnant has antibodies against the D antigen. If a mother is D negative and her baby is D positive and the mother has antibodies, they can cross the placenta and cause hemolysis in the baby. This is called newborn hemolytic disease. I talk about this in more detail in the module on blood groups. So if you're going to use the indirect antiglobulin test to screen the mother for antibodies, what you do is begin with the mother's serum and you add the mother's serum to red blood cells that are positive for the D antigen. Once you do that, you then add anti-IgG antibodies. These are the same type of antibodies we talked about using in the direct antiglobulin test. If everything swims around happily together, this is a negative test. It means there were no antibodies in the mother's serum to the D positive red blood cells. On the other hand, if the red blood cells agglutinate, this is a positive test. It means there were antibodies in the mother's serum to the D positive red blood cells. Those antibodies bound to the D positive red blood cells, and then the anti-IgG antibodies bound to those antibodies, and that caused agglutination. And this is how you use the indirect antiglobulin test. It's often used to test patients' serum for antibodies against different types of red blood cells. You can use D positive red blood cells. You can also use other types of red blood cells with different surface antigens. So here's a summary slide of the two antiglobulin tests. The direct antiglobulin test is a test for antibodies already bound to red blood cells. It's commonly used in hemolytic anemia because it answers the question, are there antibodies on the patient's red blood cells that may be causing the hemolysis? The indirect antiglobulin test, on the other hand, is a test for antibodies in the serum. It asks the question, will this patient's serum react with certain types of red blood cells? Back to our discussion of warm hemolytic anemia, let's talk about the associated conditions. So most often, warm hemolytic anemia is an idiopathic disease. However, it can occur in association with lupus, non-Hodgkin lymphoma, or chronic lymphocytic leukemia. And all of these disorders involve the immune system in one way or another, so it's easy to understand how that aberrantly functioning immune system might lead to the production of antibodies that destroy red blood cells. Another place where warm hemolytic anemia can occur is among patients taking methyl dopa. It's sometimes called alpha-methyl dopa. This is an old antihypertensive that's not commonly used anymore except in pregnancy. It's very safe in pregnancy, so it's the antihypertensive drug of choice in pregnancy. It's an agonist to central nervous system alpha-2 receptors, so the synapses will believe there is too much sympathetic outflow because methyl dopa is stimulating the alpha-2 receptors. This will cause the central nervous system to decrease the sympathetic tone in the body, and that will result in a lowering of the blood pressure. And this drug is associated with warm autoimmune hemolytic anemia. Methyl dopa triggers the production of red blood cell antibodies. The mechanism by which it does this is unclear. There are data that the drug may alter Rh antigens on the red cell surface. We'll talk about Rh antigens in more detail in the module on blood types, but the point here is that methyl dopa can modify the surface of the red cell, and once it does, antibodies will bind. And what's interesting is that once the surface has been modified, red cells will bind antibody even in the absence of the drug. That's because the surface has been altered by methyl dopa. And if you do a direct Coombs test, it will be positive because antibodies are binding to the surface of the red cell. Another drug that is classically associated with hemolytic anemia is penicillin. At high dosages, penicillin can lead to hemolysis. This occurs because penicillin binds to the surface of red cells and functions as something known as a hapten. A hapten is a molecule that does not elicit an immune response by itself, but does elicit an immune response when bound to tissues. In this case, it elicits an immune response when it's bound to red blood cells, and antibodies are produced directed against penicillin bound to the RBCs. This is a little bit different from the mechanism of hemolytic anemia with methyl dopa. But just like with methyl dopa, the direct Coombs test will be positive. And although this side effect is classically associated with penicillin, it also commonly occurs in patients taking cephalosporin antibiotics. Finally, I'll briefly mention the treatment of warm hemolytic anemia. It's often treated with glucocorticoids or other immunosuppressants, and then in severe cases it can be treated with splenectomy. Remember, you can live without your spleen, and if you take away the spleen, you take away those macrophages, which are consuming the membranes of the red blood cells. Now let's talk about cold hemolytic anemia, which is the less common type of autoimmune hemolytic anemia. In these disorders, antibodies bind to red blood cells at temperatures below 30 degrees Celsius, hence the name cold. And places in the body where the temperature gets below 30 degrees Celsius are in the limbs, where you're far away from the center of the body and the blood and the organs, also in the fingertips, toes, nose, and ears. So one of the presenting features of this disorder sometimes is painful fingers or toes, purple discoloration, especially on exposure to cold. So you can get symptoms from anemia, but you can also get these symptoms related to agglutination of red blood cells in the places where the temperature is low. In contrast to warm hemolytic anemia, cold hemolytic anemia is caused by IgM antibodies, not IgG antibodies. And remember that IgM are large antibodies that like to fix complement, and they can cause red blood cells to agglutinate, especially in the extremities, and this can result in the purple fingers and toes that patients with this condition experience. Now what's interesting is when the red blood cells warm in the central organs, the IgM is lost and falls off the red cell. However, because IgM can fix complement, it will leave bound C3 on the red blood cells, and this will cause hemolysis. It will also cause the direct antiglobulin test to be positive, but not for IgG. It will be positive only for C3. To make this more clear, let's go back to our drawing of the direct antiglobulin test. To perform this test for cold hemolytic anemia, you start with the patient's red blood cells, just like we did with warm hemolytic anemia. However, instead of adding anti-IgG antibodies like we did for warm hemolytic anemia, for cold hemolytic anemia, we add anti-C3 antibodies. Now, if the anti-C3 antibodies in the red blood cells swim around happily together, it's a negative test, and that indicates there is no C3 bound to the red blood cells. However, if the red blood cells agglutinate, that is a positive test, and it means C3 is on the surface of the red blood cells, and that's what is seen in cold hemolytic anemia. Cold hemolytic anemia is sometimes called cold agglutinin disease because the red blood cells agglutinate, and the hemolysis in this disorder is usually extravascular. That's because the C3-coated red blood cells are removed by the spleen. And in contrast to warm hemolytic anemia, in cold hemolytic anemia, the red blood cells are often engulfed whole, and for this reason, spherocytosis is much less common than in warm hemolytic anemia. Rarely you can see intravascular hemolysis, but this usually doesn't happen because the mechanism of intravascular hemolysis is complement activation, and complement usually does not activate enough to lyse the cells. The reason is because red blood cells have complement inhibitory molecules on their surface like CD55 and CD59. These are the molecules that are missing in the disorder paroxysmal nocturnal hemoglobinuria. So for this reason, C3 may deposit on the red blood cell surface because of the IgM antibodies, but usually complement is not activated to the point where it lyses the cells. Just like warm hemolytic anemia, you can see cold hemolytic anemia in CLL, but one of the most important places you want to think of this disorder is in patients who have mycoplasma pneumonia. This pneumonia infection is commonly associated with cold hemolytic anemia. You can also see it in patients who have infectious mononucleosis from the Epstein-Barr virus. So you can treat this disorder with immunosuppressants, but a simple way to treat it is just to avoid the cold. For obvious reasons, many patients like to avoid taking long-term immunosuppressants, and they can do this if they just stay warm and prevent their fingertips from getting below the temperature at which the IgM antibodies can bind to red cells. Moving on, let's talk about our next extrinsic cause of hemolytic anemia, and that is microangiopathic hemolytic anemia, or MAHA. This is caused by the shearing of red blood cells in small blood vessels, and this happens when there are thrombi in the microvasculature. This narrows the microvasculature, and as the red blood cells try to squeeze through, they get damaged, and this results in intravascular hemolysis. And the characteristic finding of microangiopathic hemolytic anemia on the blood smear is the presence of schistocytes. These are pictures of schistocytes on the screen here. They look like fragments of red blood cells. And you can see microangiopathic hemolytic anemia in the disorders TTP, HUS, and DIC, all of which I talk about in the module on platelet bleeding disorders. You can see microangiopathic hemolytic anemia in malignant hypertension. This is because the very, very high blood pressure causes endothelial damage, which leads to the formation of thrombus. This will get better with blood pressure control, but watch for the hypertension as a potential cause of hemolytic anemia in a patient who presents with out-of-control blood pressures. Shear forces can also destroy red blood cells in the large blood vessels. This is called mechanical hemolysis, and this is seen when red blood cells need to get past narrow openings around stiff tissues. So this can occur in aortic stenosis when the aortic valve is very tight. The red blood cells have to squeeze past that stiff valve, and this can cause hemolysis. You can also see it in patients who have mechanical metal heart valves, also in patients who have left ventricular assist devices for advanced heart failure. In all of these conditions, the blood needs to move past narrow openings where there are very stiff surfaces nearby, like the stiff aortic valve or the metal of these devices. In all of these cases, hemolytic anemia can occur, and you will see schistocytes on the peripheral blood smear. And then the final extrinsic cause of hemolytic anemia is a red blood cell infection. There are two infectious agents that classically cause hemolytic anemia. One is malaria, the other is the protozoa Babesia. Both of them will present with findings inside the red blood cell on peripheral smear, as shown in these ring forms and trophocyte rings. I talk about these infections in detail in the infectious disease modules, but for our purposes here, just know that when these parasites get inside of the red cells, they can lead to either intravascular red cell rupture or more commonly removal of the red cells by the spleen, and for both reasons you can develop a hemolytic anemia. And that concludes our module on extrinsic causes of hemolytic anemia.